In our time with Dr. Razuli. So thank you so much again for joining us today and taking time to just talk to our brain turns. This was a very cool
Pleasure.
talk, and I've definitely learned a lot. And so at brain turns, if we could just say thank you, that would be awesome.
Thanks so much, guys. I'm gonna just show you one thing. If you guys want to get in contact with me, you want to shadow or get more involved, I said beginning. My here's my some of my social media stuff. If you shoot me a text or shoot me an email or whatever, and just let me know, and I'd be happy to get you involved. It's always good to have more people interested in neurosurgery. And I feel like we're we're always looking for people to get interested in neurosurgery, so it's always good.
Yeah.
Thank you so much for having me.
Yeah, thank you so much.
Take care.
Thank you. All right, brain turns. So we are actually gonna go ahead and jump into our other talk. So we will also we're still staying on the topic of spine, so this is gonna be really cool today. So we have Dr. Jeffrey Zimmer joining us. He actually just finished his complex spine fellowship with Lenox Hill and like with Dr. Caridi. And he finished after completing his neurosurgery residency at Mount Sinai. So we're really glad to have you here, Dr. Zimmer. Thank you for taking time out of your schedule to join us. So I'm just going to give you the floor.
Good morning. Thank you. Can you hear me okay?
Yes.
Great. Let me just pull up my slides.
Yeah.
Can you see the full screen?
Yes, that's perfect.
Great. So thanks for having me. My name's Jeff Zimering. I'm a new attending spine neurosurgeon at Lenox Hill Hospital. I'll be starting next month, August 1st. Today, I thought I would sort of take you through the tour of spine surgery, what it involves, bring you inside the operating room, show you some intraoperative images, and then have some time at the end for some burning questions and career advice. So just to start, as a neurosurgeon, obviously my training involves surgery of both the brain and the spine, but as a fellowship trained spine neurosurgeon, our focus really is right below the base of the skull all the way down to the coccyx. And so the human spine has 33 vertebral bodies, all the way from C1 down to the last coccyx bone. And there are 31 paired spinal nerves. In the cervical spine, the spinal nerves exit above the pedicle and vertebral body of the respective level, but below the cervical spine, all of the nerves exit below the numbered vertebral body above it. And of note, the spinal cord itself, some common misconceptions is people describe the spinal cord in the lower lumbar segment, namely from L2 to L5 in the sacrum, but the spinal cord, the tissue itself, actually terminates usually between the L1 and L2 disc space, and everything below that is just free-floating nerves contained in a water balloon sac called the thecal sac. And it's really powerful and amazing to know that the spine, all of the spinal nerves really control the motor and sensory functions of your entire body. So every numbered and named spinal nerve corresponds to its matching topographical area of your body that provides sensation as well as motor function. Now, the AO Spine Foundation is one of the leading educational societies and associations that's part of training of spine neurosurgeons. And the best way to think about spine is to think of it in different categories. So we see spine trauma patients that require surgery. We see tumors of the spinal cord. We see deformity, which Dr. Rizzulli mentioned a little bit about his cases, which include scoliosis. And then there's really, I'd say the majority of patients that we see in our clinics are dealing with degeneration of the spine. So things related to aging and arthritis that often lead to degeneration of the spine and compression of the nerves that requires attention surgically. And the principles are shared amongst all of these areas. And I thought I'd go through some of these subtopics with certain cases. And so the rest of the talk will be case-based. So let's start with a case. This is a 37-year-old gentleman, history of anxiety, depression, and marijuana use. And he's presenting with 3 months of left-sided low back pain with left lower extremity radiculopathy. Radiculopathy is just a fancy word for left leg pain, and pain that's from compression of the spinal nerve. So after further questioning, the patient told me that he had 90% of his pain in his leg and 10% of the pain was in his back, so predominantly leg pain. And he said the leg pain was noted to be above the left buttock, down the side of the thigh, and the lower leg, and it stops right above the ankle. He was full strength on my examination, and his reflexes and patellar and Achilles were normal. So when we think about the examination of a spine patient in the clinic office, we really want to be thinking about the story, the history, the distribution of the pain, and how that might relate to that topographical map I showed you of which areas of the body correspond to different nerve roots. And so if we think about the L4 nerve root, it controls the function of the lower leg, being able to raise the ankle, and it gives distribution to the lateral thigh, anterior knee, and medial leg. Whereas the L5 nerve root gives great toe dorsiflexion, so you're able to raise your great toe, and you're able to invert your ankle. But the distribution is a little different in that it also involves the dorsum of the foot. And so you can see we can, with each specific nerve root, we're able to have an idea of what part of the body and function it's responsible for. So let's talk a little bit about imaging and what kinds of imaging we look for in patients that are presenting new to our clinic with new complaints. So the most basic form of imaging that we look at in spine is an X-ray. This is convenient, widely available, it's quick, cheap, and fast, and you can get this either standing or you can get it in a lying down supine position. Dynamic X-rays, that is flexion extension X-rays, are X-rays where we ask the patient to either bend forward or bend backwards, either at the neck or at the low back. And that can help us evaluate for whether there's any spinal instability. And that term is called spondylolisthesis when the vertebral bodies are sliding one in front of the other. X-rays are great for assessing a postoperative patient to look at their hardware and whether or not they've developed a fusion mass, if that's what we're trying to achieve with our surgery. But really, it's great for looking at the standing alignment, since this is one of the few studies where you're standing. And this gives us an idea of whether we've achieved a good deformity correction with patients with severe deformity issues. But it's important to note that there's no ability to visualize the nerve roots or cord compression, and it really has limited ability to assess clinical severity. We then move to CT, and a CT is great for looking at bony detail, great for assessing fractures in the spine, and great for looking at calcification of different regions of the spine. It's also very good for looking at detailed postoperative instrumentation evaluation to evaluate for what's called potentially pseudarthrosis if the patient has failed to fuse. If your intention was to fuse them, but they did not fuse, that's called a pseudarthrosis. You can also look at neural compression due to bony compression. But again, it's limited in its visualization of neural structures as opposed to an MRI. And of course, there's radiation associated with it. A CT myelogram is very similar. It's still a CT scan. However, you inject water-soluble contrast into the thecal sac via a lumbar puncture, and that allows you to evaluate changes in contours of extradural compression on the thecal sac and spinal cord. And this is done in situations where some patients may have older devices in their body that are implanted that are not compatible with MRI. Now, our gold standard modality of choice for most spinal imaging is an MRI. And this helps us look at detailed neurostructures in addition to looking at ligamentous injury, different ligaments that help support the spine and its integrity. And of course, there's no radiation with an MRI. So let's go back to our patient. Here we see this is a sagittal side-on view of the lumbar spine. These are the vertebral bodies. These are the discs in between. Can you see my mouse and cursor? Just want to make sure.
Yes.
Okay, great. So this is the L4 vertebral body. This is the L5 vertebral body. Here is the L4, L5 disc. And you can see here it's pushing on the nerves that are coming down past the L4-5 disc space. The white is the fluid that surrounds the spinal nerves, and the dark tissue is the nerves themselves. And this is all within a three-dimensional spinal canal where you have bone behind and bone in front of the spinal canal where the nerves run. Now, this is a deli cut slice axial projection through the L4, L5 disc space. And what we see here now, if this is the front and this is the back, here's your disc, okay? Here's your thecal sac, which is your nerve, which comprises of your nerve roots, which are here. And this here is a large extruded piece of disc that's herniated outside of its natural home in the disc space and is pushing on the neural elements right here. You can see there's this nice cleavage plane, but there's this pancake of the neural elements when naturally they're supposed to be taking up this entire space. This large piece of disc is pushing down and squeezing those nerve roots. Okay, and the nerve roots typically exit out through the foramen on the left side here and the right side here on axial left and right are reversed. And here are just some cartoons to show how disc material can sometimes herniate out of its disc space, where it can sometimes migrate cranially up towards the head. It can migrate caudally towards the butt, and sometimes it can even break off and become sequestered. So how do we manage patients with herniated discs, particularly in the lumbar spine? So typically we first start non-operative measures, which includes rest, physical therapy, some NSAIDs. We try to avoid narcotics, but sometimes they're indicated for short-term use. Pain management specialists, which include injections. And this is really the first line if the radicular pain is without severe weakness. And of course, there's no evidence of cauda equina or conus medullaris syndrome. And this is a syndrome which involves compression, like we showed, of the neural elements in this area, but so severe that the patient is presenting with these red flag symptoms. And what they could include are saddle anesthesia, which basically means your genital and perineal area is numb and the sensation around that area is not normal. You could start to have bowel or bladder dysfunction. You might be no longer able to urinate, or you're losing fecal matter involuntarily, and evidence of significant weakness in your lower extremities. Surgery is the mainstay option when a patient remains symptomatic, and usually this is after 6 to 8 weeks of these non-operative measures, just really not helping, and the patient still is in a lot of discomfort. And of course, any patient who presents with cauda equina syndrome should go to surgery immediately. So we've decided we're going to do surgery. So what are the surgical options? So the first is to do an open surgery. And what that means is you're doing a midline incision in the middle of the back, and you're doing a subperiosteal dissection to expose the bony coverings over the neural elements. And so a patient is flipped onto their belly, they're prone on the table. You use what's called a Wilson frame or a Jackson 4-post table. And then you have all sorts of retractors at your disposal to give yourself the best viewing for the surgery. And so that can include things like a Meyerding retractor, a Taylor retractor. This is a Williams retractor. But what you see here pictured and down here below is a McCullough retractor, which is really one of the nicer retractors for this type of procedure because it slides over the medial facets, which are much more laterally positioned without disrupting them quite easily. Now, an open procedure for this type of disc herniation is very ideal for large central disc herniations, particularly when a patient's presenting with cauda equina syndrome, because you need to do a wide laminectomy in order to expose and give yourself a nice working corridor to get all of the herniated disc out and to be able to decompress the spine satisfactorily. The other option is to do a minimally invasive surgical approach to take out this herniated disc. And that involves use of this tubular retractor system. So you get a much smaller incision. The incision is usually placed 1 centimeter lateral to the midline. And this is on either side of midline to give yourself the best entry to whether or not the disc herniation is to the left or the right of midline. You make an incision in the thoracodorsal fascia, and then you put these tube dilators down sequentially until you get yourself a nice working corridor over the interlaminar space, where you then will remove the underside of the L4 lamina, take off the ligament, and then be able to expose the thecal sac, lateral thecal sac, and then you'll see the exiting L5 nerve root the traversing L5 nerve root at this junction. And I'll show you pictures intraoperatively at the L4, L5 level. Now, some people, you may or may not have heard of neuromonitoring. So how do we know that we're not injuring nerves during our surgical manipulation? Or how do we know what their baseline nerve activity is before we even start the surgery? So we always have a very specialized and wonderful neuromonitoring team that's in the operating room during the surgery. They're usually sitting in the corner of the room. They place fine needles, stimulating and recording electrodes in the different parts of the patient's body, and at a computer are able to measure in real time the sensation as well as the motor function of particular nerves during the surgery. And so a couple of them are the somatosensory evoked potentials. These are called SSEPs. And how this works is stimulating electrodes are placed in the periphery, and then the neuromonitoring specialist puts recording electrodes on the scalp, and then they're able to continuously stimulate and monitor sensation to the desired area. And they have certain alarm criteria where they will be able to notify us during the surgery if there are any issues that might be happening. And then there are other forms called electromyography, EMG, as well as triggered EMG. And what this is doing is we're putting needle electrodes in the muscles that are supplied by the nerve roots of interest that we're manipulating and or working to decompress. It can detect any sort of touch or irritation of the nerve, and it allows us to monitor specific nerve roots. And more fine detailed is a triggered EMG, where in some situations we can actually use a stimulator to stimulate and palpate the nerve root or a peripheral nerve and tell us if this is actually nerve tissue, if we're doing a tumor resection. It can also tell us whether or not we may have a pedicle breach if we're doing an instrumentation case. And then lastly, running a motor. These are motor evoked potentials, where actually the neuromonitoring specialist will stimulate the motor cortex and then record generalized muscle contractions distally. And again, there are alarm criteria to tell us whether or not we've had a decrement in our motor signals. So the case we described, we've decided to do a left-sided approach. For a left, this disc herniation was more eccentric to the left, L4, L5, minimally invasive microdiscectomy. Well, so what is a microdiscectomy? Well, a discectomy is we're taking out the piece of herniated disc from the L4, L5 disc space, but what makes it micro? The thing that makes it micro is our visualization technique to do the surgery. And so there are really two options and mainstay options that we have right now. The first, which I used in this case and will show you, is a microscope. And here you can see Zeiss has a very nice microscope which allows us to capture beautiful images which I'll show you. And then another more recent development is what's called a video microscope exoscope. And what this is it's a camera, a microscope, video microscope camera. However, instead of looking through the microscope eyepieces directly over the wound into the surgical field, here you're wearing these 3D glasses, and your hands, although they're in the surgical field, your eyes are looking at this screen, and you're getting a 3D projection of your working field. This is a more ergonomic um, method for doing the surgery, and it really does put a lot less strain on your neck and on your back as a surgeon. So here we are, we're in the operating room. We've positioned the patient on the table. There's the head, here's the feet. We've put bolster pads around the crest of the hips. We've put chest pads here, and we've sort of given ourselves a general vicinity of where we're going to make our incision. This machine here is an X-ray machine. It's a C-arm. It slides underneath the operating room table, and it makes it very easy for us to get an intraoperative image to show us localized the correct level before we start the case. You see here, we're going to make about a 1.5 to 2 centimeter skin incision, very small. We've prepped the patient. The arms are up at their sides. We've padded all of the peripheral nerves to make sure there's no compression. And you can see some of the stimulating electrodes on the scalp and in the lower parts of the body that the neuromonitoring team in the back has placed for continuous monitoring. So here's our incision. So here's the tube that I've mentioned. Okay, these are tubular dilators. This is a 5 to 6 centimeter tube. That's the depth that will be placed before docking it on the lamina of the spine. And here's our localizing projection shot. So here's our X-ray. This is the sacrum, S1. This is L5, L4. So we're under the L4 lamina, which is right here, and we're in line with the L4, L5 disc space, which is where our working corridor will be to take out this piece of disc. So here are images captured in real time while I was doing the surgery. You can see here, first, what we want to do is we want to take off any soft tissue and muscle that's overlying the lower aspect of the L4 lamina, which is right here. And you can see that circumferentially we come around with both a pituitary forceps and a bovary cautery to burn and release some of this extraneous tissue. And now we've given ourselves our working corridor and given ourselves all the anatomy that we need to see. I know it might not seem much to you, but we have a lot of information here. So this is medial. Okay, this is medial, this is lateral. This is towards the head, and this is towards the butt. Okay, it's hard to tell here, but this is actually sloping medially. So this is the spinous processes up here. This is the lamina. This is the lower edge of the lamina. And then here you have ligament. So we're at the caudal edge of the L4 lamina here. Okay. As we get more lateral here, we'll get to the joint. Okay, the facet joint. And then as we work our way down and north, you'll get further close to the pars. But this is the entire working channel that we'll need. It's a 18 millimeter tube, so it's really no more than 1.8 centimeters in diameter of our working channel. And so we take a high-speed drill, and we're drilling off that lower edge of the L4 lamina to expose this yellow ligament. Okay, that's called the ligamentum flavum, and that covers the lower 2/3 of the thecal sac of the dura of the neural elements. So we need to expose and get through the bone in order to expose the ligament, which we will then detach. So you can see here we're using an upgoing curette to develop a plane between the bone and the ligament, because we'll take bites to take out here laterally so we get around the lateral aspect of the thecal sac. So you can see here we're using a Kerrison rongeur to take little bites of bone as we work our way north and create our field. So now what you see here is this here in the distance is the lateral aspect of the thecal sac of the nerves, okay? And then what I've done here is I've taken an upgoing curette, I've slid it in between the ligament, which is this big, thick band of ligamentum flavum that is in itself compressive and needs to be released and removed. And I've developed a plane between the ligament and the thecal sac, and I'm going to be removing all of this. And this is what it looks like after it's removed. So we removed all of the thecal sac. This is lateral aspect, medial aspect of the facet joint capsule of bone here. All the ligaments been removed, and what you're really looking at, staring at right in the face, is the dura, okay, of the thecal sac, of which cerebrospinal fluid, the brain and spine water, is contained within, as well as all of the nerve elements. Okay, and so what we're going to do now is we're going to do some more work so we can see that traversing L5 nerve root coming down and lateral, which we showed on that cartoon earlier. And so what we need to do is we need to take some more bites laterally, a little bit of taking away medial facet. That's called a medial facetectomy. And so what you see now is we've removed a little bit more bone, and you can see off the side of the thecal sac is this exiting and the traversing L5 nerve root. So this is the traversing L5 nerve root. Okay, and so we've given ourselves a nice exposure. However, we're not done yet because the neural elements are still significantly compressed from that disc herniation. So how are we going to get to the disc herniation to remove it? We need to now slide all of these neural elements medial with a suction nerve root retractor to then enter and access the disc space to remove the disc. So what we're doing here is, you see, this is an instrument that's sliding the neural elements medially, okay, exposing the disc space here. And you can see actually there's been an autoannulotomy, meaning the disc herniation was so severe that it's actually opened the disc space itself. And you'll see very soon that I'll be expressing this herniated disc material out of this disc space right here. So you can see here, you start to see the beginnings of herniated disc material, and then this monster piece, massive piece of herniated disc, which I'm taking out. This is the thecal sac, the nerves currently being compressed from this large piece of disc, but it will be relaxed momentarily. And after all that disc material is removed, you can now see very relaxed neural elements, very relaxed traversing nerve root, and that's the surgery. And the patient did quite well. Post-operatively, his pain was completely resolved and was discharged home the next morning. The next case is a 67-year-old gentleman, presents with 3 months of worsening neck pain now. Now we're looking at the upper body with bilateral upper extremity radiculopathy. The patient notes occasionally he's dropping objects and intermittent balance and gait instability, but denies any urinary or bowel dysfunction. And it's been 3 months and he's failed all non-operative management options, which we discussed previously. So in terms of his pain, he notes that there are sharp spasms and pain in the back of the neck. It goes into his trap muscles. It rides over both shoulders and travels down both arms, but it stops at the elbow. He does not have any weakness on exam, and his reflexes are okay. The same thing applies to the upper body myotomes and dermatomes that we discussed in the lower body. It's important to know your cervical nerve roots and your thoracic nerve roots, what muscles they're responsible for, and innervate what motor action you get, and the sensory distribution. The sensory distribution is key in understanding where the pain might be emanating from. So here's some x-rays we got of his cervical spine in the standing position. These are standing x-rays. And again, I discussed with x-rays, you can get what are called dynamic x-rays. You can ask the patient to flex their neck and extend their neck. And what we're looking for here is to see if there's any movement of these vertebral bodies in relation to another. Normally, they should be stacked right on top of each other with no offset. So this is cervical number 2. C3, C4, C5. These are the bones, and in between are the disc spaces. If you note at C4, C5, they don't line up exactly. The back edge of the C4 vertebral body is 3 millimeters behind the back edge of the C5 vertebral body. But what you see here on flexion, when they flex their neck, it comes back into alignment. But when they extend, it moves again. So this is evidence that this patient has what's called dynamic instability at this C4, C5 level. So that's what we're talking about here. This is evidence of dynamic instability, cervical instability, where there's a displacement of greater than 2 to 3.5 millimeters, or sometimes if you've noted an angular displacement of the bodies in relation to the adjacent segment. And then this just shows that any motion between flexion extension views is evidence of instability. So here's our patient. This is a side-on projection cervical MRI. They're looking to the side. The face is over here. This is the base of the skull. There's the cerebellum. This is cervical number 2, C3, C4, C5. Okay. At C3, C4, you notice that there's a piece of disc that's pushing on the spinal cord. Normally, you should have nice white signal, which is the cerebrospinal fluid that bathes both your brain and spinal cord. It's in continuity in a column. Usually you should have a nice signal in front and behind the spinal cord. But if you notice here at the C3-4 and C4-5 disc spaces, we lose that nice signal. And that is a result of both spondylolisthesis, so a slippage of the bones, C4 on C5, as well as disc material that's pushing on the spinal cord. And so at C3, C4, this is again our deli slice where this is front and back, left and right. Here's our disc. This is our spinal cord. Now, normally we should see nice white signal, but we've lost white signal around the spinal cord. And you can see that there's sort of a broad-based flattening of the spinal cord ventrally from the front from this disc herniation. And at C4, C5, you also see this evidence of cord contouring with dimpling of the front aspect of the cervical spine. So the surgery we're going to perform here is a 2-level anterior cervical discectomy and fusion called a ACDF. Okay. So we bring the patient into the operating room. Here's a cartoon. They're on the bed. In this case, they're on their back. They're supine. We flex their neck. We place a shoulder roll across their shoulders. We give a donut to stabilize the head. We tape the shoulders down to allow for our X-ray machine to capture the levels where we're working. We foam pad the arms, okay? And then we make this incision, usually about a 3-centimeter incision, a transverse incision. And we like to take a natural neck crease and at the levels where we're going to be operating. So it's one incision that captures the C3, C4, and C4, C5 levels. We've noted our midline here, and then this diagonal line is the medial border of the sternocleidomastoid muscle, which is apparent and one of our landmarks for our surgical dissection. So here we make an incision in the skin. Okay, we've cut through the subcutaneous tissue and fat, and we've exposed this first muscle, which is called the platysma muscle. It's innervated by the facial nerve, and we're going to have to undermine this muscle, cut through it, and do a subplatysmal dissection in order to get our planes necessary to reach the spine from the front. And so here we've started to demarcate our planes. We've identified the anterior border of the sternocleidomastoid, and we're going to follow that. There's a superficial layer of a deep cervical fascia that carries us along the anterior border of the sternocleidomastoid all the way onto the spine. Okay, and that gets us onto the spine where we then meet the prevertebral fascia, which we cut here with Metzenbaum scissors, and that allows us access to the actual bone, the cervical bones, the ventral aspect of the cervical vertebral bodies, and the disc space. So here we're moving the longus colli, which is a muscle that straddles on either side of the midline where the vertebral bodies and disc space are. Okay, and we've put these posts in to allow us to distract open this disc space where we're going to clean out all of this disc and the pieces of disc that are pushing on the spinal cord. So these posts are seated in the vertebral bodies above and below the disc space. And you can see here we're using curettes to clean out all of this disc. We make a nice rectangle. We get out laterally on both sides in order to make sure we get all of the disc material out. And we use a high-speed drill in order to contour our working channel. So once we get through the initial disc material, there's a ligament, the posterior longitudinal ligament that sits right on top of the dura. So this is the dura of the spinal cord here. And you can see here I've slid this nerve hook right above the dura and below this ligament, and we need to break that ligament. That ligament is called the posterior longitudinal ligament, and that is in itself is compressive and needs to be taken off. And so here you can see we've now decompressed the entire segment here. This is all cervical spinal cord dura, nice and free without any compression. And in order to do the second portion, which is the fusion, we need to put this inner body. Now here we've put an inner body that's made out of allograft, which is a bone. Sometimes people put titanium inside patients. It really is surgeon dependent. But we need to have this segment fuse after we've decompressed it, and so we need to place an inner body spacer here. And then we put a plate on top of it, in front of it. And so here's our final construct. We did a C3, C4, C4, C5, ACDF. There's 2 inner bodies at the 3, 4, and 4, 5 disc spaces, and then that's our anterior plating. Patient did great. The pain, most importantly, resolved, and the patient went home quite quickly and was doing well in terms of hand dexterity and balance issues at their 2-week follow-up. So that's really the degenerative side of things. A lot of patients come into your outpatient clinic with degenerative issues of the spine, and so those are some case examples. Now we're going to switch to tumors, okay? So this is a 49-year-old gentleman. He actually works in the operating room business as a surgical technologist. He's presenting with 7 years of left-sided penile, scrotal, and groin pain, as well as left leg pain. He denies any weakness or bowel bladder or sexual dysfunction. He's full strength on exam. A few weeks coming to the office, he was having some abdominal pain, and as part of the abdominal pain workup, he got a CAT scan of his abdomen and pelvis. And this is what we saw. So here's a sagittal view of your abdomen and pelvis. Here's your L5 vertebral body. This is your sacrum, S1. And if you notice in the mid-sacrum, there's a large anterior and mid-sacral mass, okay, with pretty significant anterior component. And this was followed up with a more detailed image of an MRI, which shows a very large circumscribed mass, which is also enhancing on contrast, that is taking up a good deal of the mid sacrum of this patient, and is quite compressive, particularly on the exiting sacral nerve roots on the left side at S2. So what's the next step? Well, instead of just jumping right into surgery to take this thing out, it's really important that we know what it is. So if it's a benign tumor, that changes our management from if it's, let's say, a cancerous tumor in terms of how we're going to approach it surgically. So what we do is we perform what's called a CT-guided coaxial core needle biopsy. Okay, and so what this involves is with our interventional radiologists, they place a needle into the area of interest, and they're able to sample just that area without, and most importantly, without seeding any of that material to other areas. So it's a very clean biopsy. Sorry, let me just check time. Okay, 20 minutes. So the diagnosis came back. This was a schwannoma. And as you can see here, this is a benign tumor. And this gave us our direction in how we would approach surgery for this particular lesion. So we flipped the patient on their stomach. This was a midline incision. It included an incision that went into the gluteal folds of the crease. And we were able to remove this entire tumor by performing a sacrectomy and getting this tumor out with an intralesional tumor resection. So what you see here, this is the heads up here. This is towards the butt. Okay, these are the sacral nerves, and then you can see here is the tumor as we're starting to come around it and dissect it in plane from the sacral nerve roots. You can see here we use several different types of instruments to, again, move the sacral nerve roots to the side and come around this tumor as we're starting to expose it. We're able to use these vessel loops to more easily manipulate the sacral nerve roots as we take out this tumor. And you can see here, it's quite a large area. It's quite a large tumor, and we were able to take this all out in one sitting. And so now that we've taken out all of this sacral mass, we've taken out a lot of the sacral bone, the S2 through S4 segments. Is this patient unstable? Do they need a spinal pelvic reconstruction? And the answer is yes. We found that if you do sacrectomies, particularly distal to the S1 vertebral body, oftentimes, if you don't stabilize them with screws, they oftentimes can develop more proximal sacral insufficiency fractures. And so what we did here was we placed the two bilateral sacral alar screws connected with this lordotic rod. We were able to get the whole tumor out, all of his preoperative pain symptoms resolved. Most importantly, we didn't give him any new deficits from the surgery. We did have plastic surgery close the wound, as oftentimes these patients, since you're going into the gluteal fold, that is an area that has difficulty with healing sometimes if it's not done perfectly. And so we always have our plastics colleagues help with that. And ultimately, the patient did very well. Here's another tumor case, a 34-year-old attorney presenting with 1 year of intractable low back pain, no weakness on exam, but was interfering with his activities of daily living, and he just wasn't getting any better by doing non-operative measures. And so here we have, again, a sagittal MRI looking this way. This is the front, this is the back, this is the L3, L4 vertebral bodies. Here's the L3-4 disc space, and you have this very well circumscribed cigar-shaped mass lesion that's centered at the L3, L4 disc space. So we get into the operating room. We're now exposed. We've done a L3 laminectomy right here. So these are the cut edges to expose the L3, L4 working channel. This is the dura exposed here. And now in order to get this tumor, which is intradural, we're going to have to incise, make a cut in the dura to access the intradural space to take out this tumor. So we take an 11 blade, a very sharp blade, and make a midline incision in the dura. We use this dental instrument to help us guide the whole area. We put these tack-up sutures on each leaflet edge of the dura and able to give ourselves a nice working channel. So you can see here now the dura has been opened, it's been reflected back and held up with these sutures. And now you can see here that we're staring at this very large tumor at the dorsal surface right away. And so what we do here is now we want to get to the cranial and caudal extents of this tumor. And this tumor was involved with the filum terminale, which is a fibrous band of tissue that extends down from the caudal end of the spinal cord, which we mentioned the spinal cord terminates at L1-2, and everything below that is nerve roots, but there's a piece of tissue called filum terminale, and sometimes tumors can arise from this. And so that's what we have here. And so we're using that stimulating probe, which I mentioned. This is a triggered EMG, and testing to see if there's any nerve activity here, because we're not going to want to cut this if there's any active nerves. And so nothing was stimulating here, and so that gave us confidence that we were able to coagulate it first with a bipolar electrocautery, and then cut it here with a micro scissors. And so we cut that cranial end. Okay, we now lifted this tumor up, and we're going to now access the caudal end in order to coagulate it and cut that edge as well. You can see here's its distal attachment. We stimulated, there was no nerve signal, and then we were able to cut it, as you see here. And so the tumor is now removed. What you see here are all of the cauda equina. You see beautiful nerve roots, and they're totally relaxed now. And we take the dural leaflets and reflect them back on top of each other, and then we're going to do a running suture to close this space here. So we start at one end, and then we're going to do a running suture to close the dura, and that's what you see here. And then we replace the bone. That's called a laminoplasty. So we secure that lamina that we initially took off. We secure it back on, and then we close. And the patient did very well from that. So moving on to trauma, this is a 67-year-old female. She presented with posterior neck pain, some shoulder pain, scapula and flank pain after she fell down 10 stairs. She denied any radiculopathy, weakness, or loss of hand or gait instability. She was neurologically intact on exam. This is the trauma scale. GCS-15 is a perfect exam. but she did have some pain limitation in her bilateral upper extremity deltoids, was full strength and had full sensation. As part of any trauma, there's a trauma team that does a polytrauma imaging workup. She did have a scapular fracture and some rib fractures, but her head CT imaging was fine. On CT of her cervical spine, we noted that she had a jumped facet with a fracture dislocation on the left side at the C5, C6 level. Okay, and then there was a left C6 lateral mass fracture, but there was no vascular injury in that area, and her MRI showed a pain canal. So here you see this is a CT of the cervical spine. Here's your C2, C3, C4, C5, C6. And so you can see here there's an anterior listhesis, a slippage of the C5 on C6. Usually there's supposed to be a normal alignment. There's been a significant slip. There's also widening of the inner spinous distance here. And then on parasagittal view of the joints, we can actually see, you can see here, normally the joints line up with each other. They're supposed to be like this, but here they've jumped, meaning they've sort of slid on top of each other and are not in a perfect sliding motion. They're locked. And here's a facet fracture, a left lateral mass fracture there. And here's the MRI. So you can see here the spinal cord itself doesn't show any significant compression or damage. But if we look at the stir signal, which is a sequence that shows us ligamentous injury, there's a lot of bright signal, which shows that this is a very traumatic and unstable injury. So this requires surgery. So we kept the patient in a hard collar until we brought her into the operating room. We put her in this clamp. It's a Mayfield head clamp. And then we're able to put them into this modular head positioning system, which allows us to distract and position the head and neck in terms of different flexion and extension maneuvers as we see fit, all the while neuromonitoring with any of these changes to see if any manipulations we're making just with positioning are affecting nerve function. So after we positioned and distracted the patient, we got an X-ray intraoperatively, and we actually were able to see that we were able to reduce the jump facet without any monitoring changes, just from positioning alone. But in order to make sure that they don't slip again when they stand up and get off the operating room table, we have to secure them with the instrumentation and infusion. And so we did that from C4 to C7 levels. And you can see here before this was slipped, but now the C4, C5 facet is lined up. I won't get too much into spinal deformity, although this is an area of great interest, and Dr. Rizzulli talked about this a little bit, but we treat patients across the spectrum of deformity with correction both in the sagittal plane as well as coronal scoliosis. Very common in the older population, 60% of people greater than 60 years old have some sort of adult spinal deformity. Briefly, coronal alignment is about a third of patients that have adult spinal deformity present with coronal malalignment. There are certain parameters that we look at, measurements to make sure how we're able to assess patients' alignment in both sagittal and coronal planes. But this is quite disabling for patients with functional disability, cosmetic concerns, and significant pain. Now, someone had mentioned earlier, well, what are the surgical indications to correct coronal deformity? Usually we measure the Cobb angle, so that's an angle measured around the apex of the curve. Usually patients that have an angle greater than 30 degrees makes them a candidate, and or in the coronal plane, if they have a malalignment from their central vertical coronal axis of offset of greater than 3 centimeters from their trunk, that causes any sort of disability for them. And of course, so we want to realign them, but and get them balanced in all planes. And how do we do that? Well, we have to assess the patient's curves, if they're flexible, if they're fixed and rigid. And so depending on the type of their curve and how stiff or flexible they are, we perform different types of cuts. And these are called osteotomies in the bone in order to free up the spine, in order to manipulate it into a proper orientation to then fix it with screws and rods. And so some of the more basic osteotomies are called posterior column osteotomies. We tend to utilize these for patients that have more flexible curves. And then patients with more stiff and rigid curves that need more work in terms of bony cuts in order to be able to rearrange them into a correct alignment are the higher grade osteotomies, and these are called 3-column osteotomies. So just briefly, this is a 48-year-old female, 2-year history of progressively worsening low back pain, really worsens while walking and climbing stairs. She does not have any shooting pain down her legs. She's failed all other options, and she has no stenosis, meaning tightening of her neural canal. And so we look in both the sagittal side-on plane as well as the coronal plane. You can see here our measurements tell us, and just looking at her overall, her S curve of her alignment from her head sitting on her trunk and pelvis is well aligned. So she doesn't have any deformity in the sagittal plane. But if we look here in the coronal plane, you see this wide sweeping curve. So this is a Cobb angle of 60 degrees, so much more severe than the 30-degree threshold. And so our goal is to bring this center over into alignment. And so we did that performing multiple posterior column osteotomies. So these are the lower grade osteotomies. We were able to achieve this correction with these posterior column osteotomies alone because she had a flexible spine, which we were able to see on imaging, mainly when she was lying down versus standing. When she was lying down, we were able to get her curve more corrected. And so we knew when lying down and on an operating room table, if we were able to secure in a corrected position, that when she was standing, like you see here in her post-op images, she maintained that straight alignment. And so what we do here is we use this intraoperative CT machine. It's called an Arrow. This is the operating room table. So we do the surgery on the operating room table. Typically, our workflow is place all of our screws and instrumentation freehand, meaning we're not using any assisted technology, and then we'll spin to evaluate our work. And if there's anything that needs to be corrected or make finer tweaks to, we then are able to use this navigation system right here in the operating room and to make any changes that need to do. But my training was to do everything freehand, so without the use of assisted technology. But the good news is we're able to use the technology to check our work and then make any changes if needed. So to end, I just wanted to, I guess, make it a little bit more personal, talk about myself, a little bit about pathway to become a spine neurosurgeon. I know this was touched on briefly, but obviously college and medical school. I say 4 years here. I know nowadays some med schools are 3 years. There are some combined programs, but neurosurgery residency after that is 7 years. And then a spine fellowship after that is an additional year. A little bit about me. So my first passion actually wasn't neurosurgery. It was soccer. You see here in both of these images, as a youth soccer player, I was on the U.S. men's national team. I was very fortunate to rise through the ranks and compete on the national team and in tournaments against other world-class competition. Here, where's a photo in Guadalajara, Mexico, where we were competing in a tournament, and here in northern Italy, where we were competing in a tournament. I went on to play soccer at Cornell, and really I became interested in neuroscience in college at Cornell. I was particularly drawn to learning and memory and joined a research lab where I acquired neurosurgical skills needed to conduct experiments in a rat. I also had an opportunity in college, similar to this, to shadow a neurosurgeon as part of my college's career interest program. And when I went to medical school, my mentors thought that I had the leadership skills, team play, and really physical stamina that's necessary and made me a good fit for a career in surgery. My research mentor in medical school had taught me that chronic pain can be understood as a form of learning. And since patients suffering with spinal disorders have chronic pain, I was later drawn to spine surgery during residency for the opportunity to alleviate pain and restore function in patients. So I guess final points I have and some takeaways: work hard, stay open-minded, develop interests, find mentors. Mentors are key. Be kind, be likable, and show humility, and you'll be successful and go far in whatever you decide to do. So thanks a lot for your time and attention, and happy to take any questions.
Thanks, Jeff. Hey, Christy. Hi, everybody. Sorry I'm late. Jeff, that was awesome. What a cool day. A very spine heavy day, which is great. I wanted to just sign on real quick, and there are a few questions in the chat. We will definitely get to those in a moment. Um, Obviously, we've had some technical difficulties. We are back on track. We've made some moves on the fly. We had a crazy emergency case today that prevented me from being here first thing, and so it's a pleasure. So, Jeff, I think Christy usually will run this, but I'll throw the first kind of question that is here, and it really let me see where the last one was. So people are asking a few different interesting things. So first of all, when you close with a running suture, does the dura regrow over the suture, or does the suture hold it together just from that point on? So does the suture material deteriorate, and or does it, kind of just incorporate?
Great question. So the suture material that we use to close the dura is often and typically a non-absorbable suture. It tends to scar and develop a very nice scar. In addition, oftentimes we'll use a fibrin-based glue that will squirt on top of our running suture line, which also helps scar the suture down. But um, uh, oftentimes, you get so caught up in making sure you do a meticulous tumor resection. And honestly, one of the most important things is actually next paying close attention to your dural closure, because the last thing you want to do is do a non-watertight dural closure, and then you're having a patient present with a leak of that cerebrospinal fluid that potentially was a result of your dural closure that wasn't watertight. So as long as you do a nice watertight closure of the dura, it'll scar down.
I got another good one here in the chat.
Yeah.
How long after Cauda-Equina syndrome symptoms appear is it still reversible? How long do you have basically after a
That's a great
Cauda-Equina?
question. That's a great question. So Cauda-Equina syndrome, it's the textbook answer is it's an acute neurosurgical emergency, but it really depends on the time course. So you can actually have chronic Cauda-Equina, and what that means is you can have patients who have long-standing compression of the neural elements in the Cauda-Equina region that have sort of vague symptoms that aren't presenting sort of right away acutely, and the patient may or may not notice it acutely. The symptoms may not be severe. In the in the situation where there's an acute presentation of loss of bowel bladder function, a new onset weakness from a cauda-equina compression, your best bet is to take the patient to the operating room as quickly as possible, quickly and as safely as possible. And that depends on, the hospital you're working at, the team, to make sure you're getting the operating room ready. And as soon as possible, it's ready, you really should take the patient to surgery. Now, to answer the second part of, how quickly can you recover? They say time is brain, time is spine. So from the moment the symptoms, from the onset of symptoms to intervention, the sooner you're able to intervene, the more likely someone is to recover that function that was lost. So if you're within hours, great, that patient's got a great chance. If you're within weeks from someone, or you've delayed months, or let's say they've had a foot drop for a couple months, the likelihood of them gaining complete function from that foot drop are pretty low. So sooner the better.
That's great. Excellent. All right, everyone. It's 11:59. Jeff, thanks so much for your time. Apologies, everyone, for yesterday. We are back on track. When you do things that are technically innovative, technical problems sometimes happen, but we're